Hello and welcome to 21 on 21. I'm Lester Kenyon. Today we'll be talking to Dr. Susan Mittendorf. Dr. Mittendorf is the director of the Ascension Counseling and Substance Abuse Center located in Gonzales. Good morning, Dr. Mittendorf.
Good morning. I'm so glad to be here.
Dr. Mittendorf, I'd like to talk about common misconceptions about suicide. People who talk about suicide won't really do it. Is that true or false?
No, that's false. People who talk about suicide are almost always giving us some information about their concerns and their worries, and when they talk about it, we need to take that very seriously.
Anyone who tries to kill himself or herself must be mentally ill. Is that true or false?
It's both true and false. The majority of people who commit suicide suffer from depression, and depression is a mental illness, but it's a treatable mental illness.
If a person is determined to kill themselves, nothing is going to stop them. Is that true or false?
Again, that's both true and false. Mental health professionals believe that people they don't really want to commit suicide, and they try to reach out at the last minute or toward the end of their planning process. Unfortunately, there's probably no way to absolutely stop someone who's made their mind up to do it. But the majority of people do give us a long window of time in which they would accept help and really want help.
What about people who commit suicide? Are they people who are unwilling to seek help?
No, and very often they're already receiving help, but sometimes it's not enough help, sometimes they didn't start soon enough, and sometimes individuals' problems and concerns are just overwhelming to them. So the suicide process gets underway and they're not able to stop it.
Dr. Mittendorf, what about the notion of talking about suicide may give someone the idea? Is that true or false?
Never be afraid to talk to someone when you think they're behaving in a way that's problematic, that concerns you. You should absolutely talk to them about it. You won't be giving them any idea that they didn't already think of.
I've heard that suicides are more common around the holiday season, Dr. Mittendorf. Is that true?
Oh, that's not true. Suicides are more prevalent in the spring and the summer. April, June, and July are the peak months for suicide across the United States. We think about suicides occurring around Christmas time particularly, but that's a myth. That's not true. There are no data to support that.
Are some groups more at risk for suicide than others?
Oh, absolutely. White males are at risk for suicide more than any group. Here I'm speaking about the United States. Adolescents are at great risk for suicide, and the elderly, particularly males. And among elderly males, those who are divorced or those who are widowed are at extreme risk for suicide.
Dr. Mittendorf, I know this seems like a pretty straightforward question, but why do people kill themselves?
It's a complex question. It seems simple, but it's a very complex issue. Primarily, people kill themselves because they feel hopeless and helpless and don't see any way out of their situation. But suicide is a permanent resolution to a temporary problem in most cases. And if we can just get people to understand that tomorrow things may look different, next week things may look different. This is particularly the problem with adolescents because they don't have any life history to draw on. And whatever they're experiencing at the time is the worst thing they ever experienced. So if a young man gets dumped by his girlfriend, for him at that moment it's the end of the world. And if you complicate that with impulsive behavior and substance abuse, that's a very severe potential suicide risk for that individual. So we also think that people commit suicide because they're terribly depressed. And although most depressed people don't commit suicide, most suicidal people are depressed. And that's a very important thing to keep in mind.
Do people attempt suicide to prove something in order to get sympathy?
Well, I couldn't say it never happens, but I think that's not the primary reason. I think people really experience genuine despair and hopelessness. And really see no way out of their situation. And the thing that you have to keep in mind is that depression, one of the symptoms of depression is a distortion in the way somebody normally thinks. So you or I might say, well, I'm having a bad day, or this is a pretty bad situation I'm in, but I know that it can get better. I've been in bad situations before, I'll work it out. But when a person is chronically depressed, they get worn out from trying to deal with their issues, and they don't have the coping skills that healthier people have. So they simply can't deal with it anymore, and that's when you see a lot of suicides.
Dr. Middendorf, is depression the same as the blues?
No. Depression, clinical depression is an extended period of feeling sad, feeling hopeless, feeling very lost and unable to think positively about either the present or the future. And depression is a very serious illness, and it needs to be treated most effectively with medication and psychotherapy. We have very good luck, probably 90% of the cases 90% of the individuals who are experiencing those severe symptoms can be helped.
What causes a depressive illness?
Depression is caused by an imbalance in brain chemicals. Depression, the brain is an organ of the body, just like hearts or lungs, or other parts that we have, and our brains get sick. And serious depression is caused by an imbalance. That's why medication is so helpful in addressing those conditions. We have wonderful medication now with very few side effects to help people who are depressed, and a good psychiatrist can help find the right medication for the right individual. It's very, very encouraging.
If someone has a family history of depression, are they more at risk to have the same thing, the same illness?
Yes, you are more at risk for depression. You're predisposed, but that doesn't mean necessarily that you're going to have it. We know that depression runs in families, just we know that alcoholism runs in families. So if you have a family history of depressive illness, it would be very helpful if you were concerned about that, and if you would talk to someone, get evaluated if you're feeling very depressed. It does run in families.
Dr. Middendorf, why does depression sometimes lead to suicidal thoughts?
Well, just as we said earlier, people get worn out. They get depression's very exhausting. It affects your ability to sleep, for one thing. So someone who's severely depressed may not be sleeping well at all. And it doesn't take many weeks of not sleeping to begin to have distorted thoughts and to feel completely hopeless and to not be able to see any future for yourself or your situation. And I really think people just get worn down and run out of options. The options are there. They just are not able to see them.
Can depressive illnesses be treated?
They can be treated. They can be treated very effectively in young people, in adults, and in the elderly. And we have a whole set of options for treatment that any good psychiatrist can help you find. It's important that you find the right treatment for the right individual. The same medication doesn't suit everyone. So someone might say, well, I went to a psychiatrist and I tried some medication and it made me jittery, so I stopped taking it. And what people need to do is go back until they find the right medication. It's not as easy as treating hypertension or diabetes, both very serious illnesses.
Dr. Middendorf, why do people not want to talk about depression or suicidal thoughts?
There's an enormous stigma attached to mental illness, and depression is a form of mental illness, and I think people are embarrassed. I think families are embarrassed. I think friends are embarrassed. They don't want to point out to someone that they think they have a mental illness, so we all probably keep quiet when we should be speaking to people that we love about what their behaviors and our concerns about their behaviors.
And how do drugs and alcohol use affect depression?
Alcohol is a central nervous system depressant. And people often use alcohol to treat depression, their own depression, quietly in their house. In doing this, what they wind up doing is making themselves more depressed. Temporarily they feel better, but after some period of alcohol use they become more depressed, so they tend to use more alcohol, which in turn makes them even more depressed. And while all of this is occurring, their inhibitions are decreased. So when someone is using alcohol, they don't have their same sense of, oops, I shouldn't do this, this isn't a good thing, I need to get help. All that's gone. All their inhibitions have been removed by the alcohol. So we see a lot of suicides among people who are using alcohol, and some among drug users.
Dr. Mittendorf, can suicidal people hide their depression?
Yes, they can. They can't hide depression from somebody who knows them really well, but they can hide depression from coworkers and friends that they don't know quite so well.
Why do people attempt suicide when they appear to be feeling better?
Well, there's a phenomenon among mental health professionals that we're very familiar with. When a person is profoundly depressed, they frequently don't have the energy. They might develop a suicidal plan, they might even get the means, but they don't have the energy to complete the process. When they are treated for their depression and begin to feel a bit better, they have more energy and they're able to complete this suicidal plan that they may have had all along. So we often see suicides occurring after somebody's had a bit of treatment. The trick here for a professional is to monitor their patient very closely and to, whenever possible, have the support of the family in helping to keep that person safe through that process. They quickly move up the scale to feeling better once their medication is working. But there's a period in there of a few weeks that are very risky.
Dr. Mittendorf, if a person has made up their mind to commit suicide, can they still be stopped?
They can, and in most cases they can. In the cases where they hide it completely, we don't get a clue, we can't do anything. But if you're absolutely convinced that someone's going to commit suicide, they need to go to a hospital right away, and you need to take them. People who are concerned about friends and family members, the friend or family member might not be happy about it, they might be angry at you, but you can work that out later when they're still alive. You can take a person to any emergency room in any hospital. St. Elizabeth's Hospital will receive them and see that they're taken to another inpatient facility where they can stay until they're stable.
Dr. Mittendorf, I'd like to talk about the risk factors for suicide. What are the risk factors?
The most critical risk factor for suicide is depression. In the presence of depression, we have to always think about the possibility of suicide. The next most important risk factor is a past history of attempted suicide. When someone has previously attempted suicide, they are more likely to attempt suicide a second time. And it also indicates that depression is most likely present with that individual, chronic depression. A third risk factor is a genetic predisposition, a family history of suicide, or a family history of depression, or a family history of alcoholism, which often suggests depression. Another risk factor is impulsivity. When individuals are impulsive, when they don't think before they act, they're more likely to act on a suicidal impulse. As we said earlier, substance abuse increases the risk for suicide greatly. And the last major risk factor is belonging to an at-risk group, males, white males, adolescents, or people who are elderly. There are some other risk factors that are important. A family history of child maltreatment. Abused children often grow up to be depressed adults. Feelings of hopelessness, impulsive or aggressive tendencies, barriers to accessing mental health treatment, Loss is a big factor in suicidal risk. Losing anything, losing a job, losing a loved one, sometimes moving, anything that uproots you from your comfortable or accustomed life. Easy access to lethal methods. Having guns lying around is a risk factor. Unwillingness to seek help because of the stigma attached to mental health and substance abuse disorders. A lot of times it happens that people know they're depressed and their friends know they're depressed, but they know that the individual is not going to seek any form of treatment. There are also cultural and religious beliefs. In some cultures, suicide is thought of as a noble thing to do. That's not consistent with our American culture, but it does exist in other cultures. Isolation is a risk for suicide, people who are cut off and out of contact with others. And interestingly, local epidemics of suicide is another concern. You see this among adolescents where 1 or 2 or 3 kids will commit suicide, and then that seems to set off a whole set of suicides.
And Dr. Mittendorf, what are some of the protective factors that are done to prevent suicides?
The most important protective factor is support and involvement with other people, family, friends, co-workers. Isolation is the real enemy and the risk factor that we need to combat the most. And it's very easy to involve an individual, to reach out to them, to talk to them, to telephone them, and keep them from isolating themselves. So loving family, caring friends, probably the major protective factor.
Dr. Mittendorf, I'd like to talk about helping the suicidal person. What are some of the warning signs of a suicidal person?
Isolation, a loss, increased alcohol use, presence of guns, talk. Suicidal people most always talk about their concerns, and they say things like, my family would be better off without me. At least they'd get the insurance money, which is, of course, not the case if you commit suicide, but people often say that. They might genuinely believe that people who love them would be better off without them. But suicide is a tragedy. No one is better off without the person that they love. Families never understand it, and they never get over it, ever.
Dr. Mittendorf, what should a person do if they suspect that their friend or their family member is severely depressed and perhaps suicidal?
They need to do 2 things. They need to talk to the person, to raise their concerns, and they need to help that person get help. And as we said earlier, that may make the person mad initially, and you have to be willing to put up with that. You can work the relationship issues out in the future, but you need to understand this is a critical issue and needs to be addressed immediately. It's not something you can just sort of watch happen. We've had some very tragic suicides in Ascension Parish in recent months, and everyone has been upset and concerned about them. And I know that people in these situations may have tried very diligently to interfere with this cycle and prevent it, but we may or may not be successful, but we all have to try.
I guess this leads to one of my final questions. Where can someone in this parish get help?
You can go to any hospital emergency room. You can go to your community mental health centers. Ascension residents are very fortunate to have 2 excellent community mental health centers. Ascension Counseling Center, my agency, and Gonzales Mental Health, the state agency, both of them located here in Ascension Parish. You may also go to your family physician. Any physician can help you. You can go to your minister.
If you feel that someone isn't in immediate danger, what should you do?
I would strongly encourage you to talk to them about having their depression evaluated. It's very hard to get people to take that first step. You might want to go with them to their first appointment Even, you just go and sit in the waiting room and let them be evaluated. Call in, help them make an appointment. Take them to their doctor. And just continue, the message has to continually be, I'm worried about you, I'm concerned about you, I want to help you, please let me help you.
Well, thank you, Dr. Mittendorf. And are there any numbers that you'd like for us to get out to the public, telephone numbers? Or?
Yes, I'd like you to put out the number for the phone, the Baton Rouge Crisis Intervention Center number.
Dr. Mittendorf, thank you very much for speaking on this topic.
And thank you very much for having me.